Good evening. I'm Elizabeth Beutler, and this is my Doctor in Nursing Practice Project PowerPoint presentation titled Burnout Among Nurses Who Worked on the COVID Units. And I'd like to introduce you to my committee members, my chairperson, Dr. Galakatos, second reader, Dr. Snell, and community member, Dr. Vincent Yang. And I'd like to thank them for their support during this process. This next slide is my educational background. I earned my bachelor's degree in nursing from Washington State University in 2007, my master's degree with a family nurse practitioner concentration in 2014, and plan to graduate with my doctor in nursing practice degree from Maryville University this month. I'd like to introduce you to the background and significance of this project. This project was all themed around nurse burnout. And burnout is described as exhaustion, depersonalization, and reduced personal accomplishment. In a recent study, 54% of first-year nurses suffered from at least moderate burnout, with an increase in burnout symptoms of 10% after their first year. The impact of nurse burnout resulted in a 12% nurse staff turnover rate, which is significant for an organization. When nurses feel burned out, they feel they aren't performing their job duties at the expected level. That results in a lack of motivation and poor personal job-related self-esteem. The Tri-Council, funded by the American Nurses Foundation, held a virtual summit in December of 2020 to discuss nursing successes and failures during the COVID pandemic, implication for nursing education and regulation, and created a framework for post-COVID healthcare advocacy and change. The recommendations made during the summit requires an organizational response to help nurses with self-care. A rapid response is needed now to support nurses before they burn out, quit, or leave the profession altogether. It is vital for organizations to provide nurses with the necessary support and interventions to reduce the physical, mental, and psychological impacts caring for patients with COVID-19 has had on them. In March of 2022, President Biden signed into law the Dr. Lorna Breen Healthcare Provider Protection Act that is designed to ensure healthcare professionals are provided with mental health support to address burnout. Dr. Breen was an emergency room physician in New York who worked during the COVID pandemic. She worked closely with COVID patients, acquired COVID herself, recovered, returned to work, then tragically died by suicide. Prior to this pandemic, she did not have any known diagnoses of mental health issues. This is one instance that outlines the mental health impacts caring for COVID patients has had on caretakers. Nurses face insurmountable challenges during the COVID pandemic, knowing that they had to reuse N95 masks, wore garbage bags to work, knowing there was a shortage of gowns, and care for patients who needed ventilators, knowing that ventilators were being rationed, care for patients knowing they would eventually die alone. But nurses continued to show up anyway. The impacts of COVID-19 were beyond physical and mental. Caring for patients with COVID-19 also had psychological impacts, including fear, frustration, anxiety, stress, depression, and social isolation. The fear of infecting family members or other patients was the main concern that nurses expressed. Other nurses reported feeling anger, compulsivity, obsessive thoughts, apprehension, and betrayal. When comparing the mental health of nurses pre-pandemic to during the pandemic, a higher incidence of mental health symptoms occurred during the pandemic. This leads us to the DNP question, Doctor Nursing Practice Project question. Will a 10-minute per day mindfulness intervention over a 30-day period reduce the feelings of nurse burnout among those who worked at least 100 hours on a COVID unit at a long-term acute care hospital? The purpose of this project was designed for both quality improvement and practice improvement. This project was aimed to identify nurse burnout in a population and address it with a daily mindfulness intervention. Burnout among nurses has a direct correlation with lower quality and safety ratings. Thus, in theory, reducing burnout will elevate quality and practice improvement. The population studied was nurses who worked on a COVID unit for at least 100 hours at a long-term acute care hospital in the Western United States. Multiple articles were reviewed and analyzed for the review of literature portion, and the nurses reported feeling overwhelming exhaustion and a sense of ineffectiveness while caring for COVID patients. That was a common theme among most of the articles. Lack of personal protective equipment, high patient workloads, and the uncertainty of the virus left nurses feeling worn out and depersonalized. Those with decreased support systems, including lack of social support and emotional support, were more likely to burn out. The articles also discuss strategies to address burnout, which include self-care measures, building up resistance with stress training classes, and organizational support to help them. All articles examined for this literature review examined the prevalence of COVID-related nurse burnout, detecting risk factors leading to nurse burnout, and described associated mental health and organizational consequences of untreated burnout. During the pandemic, frontline workers, especially nurses, were caring for high volumes of acutely ill patients. Recent studies have shown that pre-COVID, 20 to 30% of frontline healthcare workers had considered leaving their professions. In the spring of 2021, during an active phase of the COVID pandemic, 43% of bedside nurses were thinking about leaving their current positions. So this was an increase from pre-COVID from 20 to 30% up to 43% during COVID. An additional 5% of intensive care unit nurses, so 48% total, also reported a desire to leave nursing. The information learned from this robust literature review provided a foundation for this project. Orum's self-care nursing deficit theory was the theoretical framework that was chosen for this project. Orum's self-care theory evaluates one's ability to maintain physical health, such as activities of daily living and hazard prevention. According to this theory, self-care deficits occur when one's self-care agency is not adequate to meet one's physical needs. This theory applies to the phenomenon of nurse burnout. When nurses are unable to provide self-care agency to meet the mental health needs, there's a self-care deficit on a psychological level that can result in burnout, depression, anxiety, stress, exhaustion, and depersonalization. Orum's self-care theory has been implemented in prior nursing research. Tanaka 2022 applied this theory while researching nursing students who were experiencing burnout syndrome. Findings reflected that many of the nursing students felt trapped, defeated, and detached due to burnout syndrome in the form of mental and physical exhaustion, as they reported having little time to satisfy their personal needs. In this specific research project, Orum's self-care theory effectively identified burnout and depression among nursing students with proposed interventions to encourage self-care activities to address it. In this project, Orum's self-care deficit nursing theory was used to help with the coping needs of nurses who care for COVID patients. Orum's theory supports strategies that increase resiliency and reduce burnout. This project used a quasi-experimental pre-test, post-test design using the Mazak Burnout Inventory Scale, or MBI. MBI pre-tests were completed by participants within 5 days of starting the 30-day intervention phase. During the 30-day intervention period, the nurse is engaged in a mindfulness intervention for at least 10 minutes per day. MBI post-tests were completed by participants within 5 days post-intervention phase. The Maslow Burnout Inventory Scale, or MBI, measures 3 phenomena, including exhaustion, depersonalization, and personal level of accomplishment. This is considered to be the gold standard scale used in research to measure occupational burnout due to its reliability and accuracy. The higher the exhaustion and depersonalization scores, the higher the level of exhaustion and depersonalization the nurse experienced, hence the higher level of burnout in those categories. Whereas the higher the personal accomplishment scores, the more the nurse feels personal achievement and success, hence the lower the burnout the nurse experienced in that category. Since 2 of the categories reflect higher burnout with higher scores, and the 3rd category measures higher burnout with lower scores, the total from the MBI questionnaire is not used to provide meaningful data. For this reason, all 3 categories are analyzed separately. Let me introduce you to the sample information. So we started with 49 participants. 5 of them dropped for various reasons, leaving us with 44 who completed the study. Maryville University statistician advised that at least 41 participants were needed to reflect statistical significance. So we started with 49 to give us some leeway, with the 5 dropping, and this still allowed us 44 participants who completed the project. So we had above 41 with the 44. The nurse participants must have met the following inclusion criteria and agreed to the terms of the project and signed the informed consent form. The participants were registered nurses at a long-term acute care hospital in the Western United States. They all had active, unencumbered registered nurse licenses. They were all employed at the long-term acute care hospital for at least 6 months prior to the start of the project, and all had worked at least 100 hours on a COVID unit at that long-term acute care hospital. Of those who completed the study, there were 32 female and 12 male, and there were 19 Caucasian, 15 Filipino, 4 African American, 3 Hispanic, 2 Indian American, and 1 of other ethnic backgrounds. All of the participants self-reported, so this wasn't confirmed, living within 30 miles of the long-term acute care hospital in the Western United States. Both the Kolmogorov and Shapiro-Wilk tests were used to assess normality. And the data analysis was performed with a paired t-test. So a paired t-test was used to analyze the 3 sets of data. To run a paired t-test, certain assumptions must be met. One of the assumptions is the variables must be normally distributed for both the pre-test and the post-test, and the data collected for this project was. The mean pre-test and post-test scores of all 3 categories reflected small yet statistically significant reductions in burnout. This reflects the data findings. So you can see here that the mean pre-test exhaustion score was 36.45 with the post-test mean 34.30. So right here you can see that there was a 2.15% difference in the mean pre-test versus post-test in the exhaustion, but these numbers still landed them in the high burnout category, pre-test and post-test. The mean pre-test personalization score was 34.95 with post-test 33.86. So here there was a 1.09% or a point difference in the depersonalization scores. Both still, the means landed both the pre-test and the post-test personalization scores and high levels of burnout category. The increased personal accomplishment scores should reflect a mean of 8.7 with an increase. In this case, we wanted an increase. The higher the number, the higher level of personal accomplishment. So then we went up to 9.16, which showed a 0.46 point increase in personal accomplishment. Both the exhaustion and burnout scores, both the exhaustion and depersonalization scores reflected a small yet statistically significant reduction. Okay, so this is the results slide, and it reflects the personal accomplishment, the exhaustion, and the depersonalization. So if we're looking at the power scores here, most would consider an adequate power score to be 0.8 or higher. And as you can see here, the exhaustion had a 0.99, which is a very strong power score. The personal accomplishment had a 0.979, again, very high, much higher than 0.8. And the depersonalization power score is 0.726, so it's not quite 0.8. As we know, as the power score increases, the chance of making a type 2 error decreases. So even though this isn't a 0.8 score for depersonalization, it still shows some statistical strength, but not as much so as the exhaustion and the personal accomplishment. The paired one-tailed t-test results are shown here. After statistical analysis using the paired t-test were run, it does show that there was statistical significance between the pre-test and post-test scores of all three categories. This study did have limitations. The data collected reflected strength and clinical significance. However, the effects of the intervention did not show enough strength to reflect real changes in burnout. As you saw on the prior slides, even though there was a reduction in the exhaustion and depersonalization scores, the reduction of the scores post-test still landed the mean, the average scores in the high burnout categories. A future study lasting more than 6 months may be indicated to show significant improvements. So this was only a 30-day period, not really enough time to show much improvement. The goal would be with more time, hopefully we would see more significant improvements and hopefully get those nurses out of the high burnout range. Collaboration with the long-term acute care administration to take a dynamic approach in reducing burnout may be another attempt. Many of the nurses' scores plus intervention show the nurses weren't as highly burned out but still landed them in the high burnout range. Organizational interventions combined with self-care interventions may show a greater improvement in burnout. Not only will organizational efforts potentially help improve burnout, but it will provide additional support for nurses in the workplace. Organizational support has been shown to increase job performance, nurse retention, and loyalty to the institution. Previous studies have shown that effectively reducing nurse burnout involves a multifaceted approach involving both the nurse and the organization. This means that effectively reducing burnout is up to both the nurse and the organizations to provide interventions. Nurses have the responsibility to engage in self-care measures, as organizations have a duty to provide a supportive work environment with reasonable hours, workloads, and expectations to prevent nurses from feeling overworked and burned out. Organizations are also encouraged to provide stress reduction and mental health resources for all nurses who are interested. There was suspicion the burnout scores would come back high, but almost all 44 participants, so 41 of the 44, scored in high-level burnout ranges for all three categories. Even with a reduction of burnout scores post-intervention, 41 participants still reflected high-level burnout scores on the post-test. Although the MBI post-test score showed statistically significant improvements in burnout, the improved burnout scores still landed most of the nurses in the high-level burnout categories. Based on the findings, there are implications for nursing practice. The findings from this project reflect a dire need to evaluate and treat nurse burnout. The physical and mental health of nurses is being compromised by the demands of their workplaces, and nurse burnout has a remarkable impact on quality and safety. The high levels of nurse burnout, as reflected in this study and others, should be alarming to the healthcare community at large. The implications of nurse burnout threaten the stability of the nursing workforce. This study indicates the need for a rapid response to save our nurses from leaving the bedside or leaving the profession altogether. This data also suggests the importance of teaching nurses self-care interventions to prevent and deal with burnout. Additionally, findings illustrate the importance and responsibility of hospitals and facilities to take care of their nurses. In conclusion, nurse burnout is a complex phenomenon that is not easy to solve. There are many layers to this issue, and there is no easy solution. Additional research is needed to study other self-care measures nurses may engage in to reduce burnout. Research is also needed to examine the effectiveness of organizational approaches to reduce burnout. Based on the findings of this study and extensive analysis of similar studies, reducing burnout is dynamic and involves the participation of nurse advocacy groups and associations, policymakers, organizations, and nurses. Thank you for allowing me to present my Doctor in Nursing practice project to you today. If you have any questions, please submit them via email at my email listed below. This next slide is my reference page, and have a great day. Thank you.